right. Hi, my name's Emma, and I am going to be presenting on dissociative identity disorder today. So first we have a brief overview of what I will cover in this presentation. First, I want to start with the DSM and DID expert definitions of the disorder, including its core symptomatology and concurrence with other disorders, and the general and DSM history of DID. Then we'll discuss etiology, diagnosis, and treatment, all of which have controversy and ethical issues surrounding them. So the DSM-5 definition of DID is a dissociative disorder in which an individual experiences two or more distinct personalities and has recurrent episodes of amnesia. It also acknowledges that the existence of personality states is considered as possession in some cultures, so it even makes allowance for a possession form DID, and it clarifies that it has to be outside of normal cultural experiences for a diagnosis. And then outside of the DSM, DID experts describe it as being a complex post-traumatic development disorder. The symptoms of DID are outlined in the DSM, and they can be described in 5 categories. And those are depersonalization, derealization, identity confusion, identity fragmentation, and amnesia. The first 4 discontinuities of experience can involve feeling as if one doesn't have control of their own body, things like hearing voices, changes in perception of the world and self, and changes in functioning. And then dissociative amnesia has 3 elements: gaps in memory about personal life events, lapses in dependable memory, and discovering evidence of things that someone with DID doesn't remember doing. And then a couple of studies have discovered comorbidity with PTSD and borderline personality disorder. Those are the ones it's most comorbid with. And comorbidity with PTSD is attributed to the idea that both PTSD and DID are the result of traumatic experiences. And borderline personality disorder has some very similar symptomatology to the point that it has been confused with DID. But while they both involve depersonalization and derealization, DID has the unique symptoms of amnesia, identity confusion, and identity fragmentation. All right, so for history, the early 20th century is when the term dissociation was brought into psychology, and books started to be written about cases of people exhibiting multiple different personalities. A couple examples of the first books written about this are The Three Faces of Eve and Sybil, both of which were made into movies as well. The dramatization of the disorder brought it into the public eye and attracted scholarly as well as public interest. The body of academic literature written about the disorder increased greatly during the last couple decades of the 1900s. And then with the DSM in 1980, with the publication of DSM-3, dissociative disorders were added along with PTSD and somatoform disorders, and the diagnosis of hysterical neurosis was taken out of the DSM. DID was originally referred to as multiple personality disorder, even in the DSM, until it was updated to being called dissociative identity disorder in 1994 with the publication of the DSM-4. The fact that DID is even in the DSM is controversial because some clinicians and researchers don't consider it to be legitimate, and those are for reasons that I will elaborate on next. So for etiology, the trauma model is the assumption that the DSM operates by, and it asserts that the root cause of DID is childhood trauma. This understanding was developed because the common factor in individuals diagnosed with DID has been found to be a history of childhood abuse or trauma. In some cases, it was only self-reported, but in other cases, history of severe abuse has been confirmed by outside sources. Following this model, individuals subconsciously develop alternate identities to cope with trauma. So from childhood, they don't have a fully integrated sense of self because of this trauma. And then on the other end of the spectrum are actually many clinicians and researchers as well who believe that DID is not a result of trauma, but that it is developed as a result of outside influences, which could be treatment or media portrayal. It is known as the sociocognitive iatrogenic or fantasy model. This thought suggests that individuals diagnosed with DID are highly susceptible to suggestion and fantasy. So if their therapist tells them that they have DID, they will easily believe it and even go on to believe that they have alternate identities and memories hidden in their subconscious. Or someone might see the dramatization of DID in media and start to believe that it is true of themselves. If this is true, then there are obviously very serious ethical issues, because that would mean that a therapist is causing disordered thought in their patient. Scholars who subscribe to this belief often see the diagnosis of DID as a fad that was popularized in the past century, and that it'll just pass with time. Proponents of this also cite sources that have shown that inner identity amnesia didn't actually exist in participants with DID, which means that the person actually did encode memories from alternate personalities. So that only takes down part of the theory of DID. So there's extensive literature arguing from both sides of the trauma model and sociocognitive model, but the lack of clarity and determination is due to the lack of empirical evidence to support either side. Essentially, neither side has produced sufficient evidence to prove that their line of thought is correct. The argument against the trauma model is based mostly in that it is heavily reliant on self-report, but it hasn't been proven that any or all cases are inaccurate diagnoses. Then the argument against the sociocognitive model is that there are many people diagnosed with DID and experiencing these symptoms, so obviously it does exist. And then somewhere between these two theories stand psychologists who believe in the validity of the disorder, but suggest that we need to consider other causes beyond trauma, because trauma can lead to so many other responses as well. These clinicians suggest that there must be some other commonality that influences people to develop DID. So the diagnostic tools for DID are various self-report questionnaires and clinical interviews. The standard procedure preceding diagnosis involves having a patient fill out the dissociative experiences scale and then interviewing them with the dissociative disorders interview schedule or the structured clinical interview for DSM dissociative disorders. There's controversy about diagnostic measures for this disorder because they're so heavily reliant on self-report, and there is not much external evidence, especially if an alter never shows up during therapy, so the therapist can't see it. Concerns about the validity of the diagnosis have also been raised by people who believe it would be easy for people to malinger DID. There have also been a couple studies that sought to identify if people could be coached into effectively faking DID, and these studies found that simulators weren't able to accurately fake DID when measured measured with the Minnesota multiphasic personality inventory or the tested memory malingering compared to legitimate or people who had been diagnosed with DID. So the estimation of the prevalence of DID in the United States is about 1%, but many people argue that it is overdiagnosed, and then there are the people who also argue that it is a complete misdiagnosis. Another consideration about diagnosis is that studies have found that individuals who were diagnosed with DID often have spent 6 to 12 years in the mental health system before they were properly diagnosed with DID. And most of the research and discussion about DID is in the US and Europe, although there have been multiple studies in the past that have sought to diagnose DID in populations outside of the US, including Canada, Turkey, Norway, Switzerland, Germany, and China. And in each of these studies, cases of DID were identified in patients who had not previously been diagnosed with DID, and DID was virtually unknown in those places as well. So people use that to argue that that it is a legitimate diagnosis and that it is not just a made-up or a fantasy diagnosis. So following the trend of controversy regarding DID, treatment is another area of disagreement and ethical concerns. Unfortunately, there is no evidence-based treatment currently available for DID, and there is hardly any systematic research on the effectiveness and efficacy of methods used. But the most common and supported treatment for DID is currently phasic therapy. Phasic therapy is a psychodynamic trauma-focused psychotherapy recommended by the International Society for the Study of Trauma and Dissociation, and it has 3 phases. The first phase is focused on establishing safety, stabilization, and symptom reduction. The second is confronting and processing traumatic memories. And then the final stage is integration and rehabilitation. The first phase is the most emphasized because stabilization is seen as essential for the well-being of the patient before ever approaching trauma. This therapy has been most practiced in treating DID, has been improved over time, and it appears to be effective in reducing symptoms in many cases of DID. But in the past couple years, some clinicians have suggested schema therapy as an alternative treatment because of the extreme length and expense of phasic therapy. And they also argue that phasic therapy spent too long in phase 1, which is stabilization, and that it is necessary to the well-being of patients with DID for them to be able to confront their trauma. So if they don't get to that stage or they spend too long in the first stage, then that's not doing right by the patient. So their idea of schema therapy was to adapt this already existing treatment that's been used particularly for borderline personality disorder, but adapt it to better fit DID. Schema therapy is supposed to be on a timeline of about 1 to 3 years, as opposed to the several years that phasic therapy takes. And it is focused on reframing different identities as modes of one sense of self, rather than the distinct and separate personalities. Schema therapy is in the beginning stages of formulation, and so far it's been proposed, and then it's also been contradicted, but that's about as far as it's gone. And then ethical concerns about treatment mostly surround phasic therapy because that's what's been done, and people are concerned that the hypnosis and actively searching for alters that's used in this therapy sometimes can lead to extreme distress and potential harm due to the reliving of traumatic experiences, essentially. But at the same time, without it, it's hard to solidify the diagnosis. If you don't uncover the trauma, then it's harder to make progress. So then other concerns with treatment arise from the previously mentioned sociocultural or iatrogenic model of DID, which suggests that therapy can actually instill the characteristics of DID in patients, which if that is true, then that would obviously be a great concern. So despite the extreme controversy and disagreements surrounding this disorder, there is agreement across the board that much more research is needed because there's hardly any, there's just a lot of literature of theorizing and people disagreeing with each other and going back and forth that way, but there's not much empirical evidence to go off of. So we need more research to know how to best approach the diagnosis and treatment of DID, to investigate validity of the disorder and diagnostic tools, and also to look into the efficacy of both phasic and schema therapy. So that's all I have for you right now, and I look forward to discussing this further in class on Thursday.